Good morning, good afternoon, and good evening. Welcome all of you to the live program number 171 at Orthopedic Principles. Today, our guest of honor is Dr. Kowshik Jain from the United Kingdom. Dr. Jain is an orthopedic foot and ankle surgeon associated with the Dudley Group of Hospitals at the NHS Trust. After his post-graduation from India, Dr. Jain obtained MCH degree from the Edge Hill University and also completed his FRCS Trauma and Orthopedics in 2014. Completed a BOA Foot and Ankle Fellowship in 2015, and since 2017, he has been associated with the Dudley Group as consultant foot and ankle surgeon. He's been faculty for the Wrightington FRCS course, is a certified ATLS instructor, and has been a peer reviewer for the Bone and Joint Journal. He has over a dozen publications and case reports to his credit. Today, it's my great honor to introduce you to Dr. Kowshik Jain from the United Kingdom. Over to you, Kowshik.
Thank you so much, Hitesh, for the kind introduction. Hello, everyone. So my talk today is on principles of ankle arthroscopy. Right. So this is where I work, and this is called the Midland Orthopedic Center in a place called Dudley, about 15 miles from Birmingham in Midlands in the United Kingdom. Ankle arthroscopy has come a long way. Broadly, you can divide ankle arthroscopy into two groups: anterior ankle arthroscopy and posterior ankle arthroscopy. For the purposes of this talk, I'll stick to anterior ankle arthroscopy because posterior ankle arthroscopy is a separate talk in itself. Okay. My talk, hopefully, it should be 30 to 45 minutes long, and it's divided into these 5 subheadings. I'll start off with a brief introduction into history and evolution of ankle arthroscopy. We'll talk about some indications and contraindications. And the most interesting parts of my talk would be the equipment and the actual technique, and some tips and tricks that we can do with ankle arthroscopy. Finally, a brief note about some of the complications which can happen. Right, starting with introduction, as many of you might be aware, Japanese surgeons have contributed a lot when it comes to arthroscopy in general. Watanabe is the father of arthroscopy, and he was the first person to perform knee arthroscopy, as many of you know. The first report of ankle arthroscopy was from another Japanese surgeon. His name is Takagi. In 1939, he published a report on ankle arthroscopy. But one of the most significant developments was Watanabe's paper in 1972, where he published results on 28 patients. It was the biggest series at that time, and he gave technique and performed anterior and posterior ankle arthroscopies on these patients. Over the past 2 to 3 decades, there has been an explosion in improvements in ankle arthroscopy, expansion of indications, and in general day-to-day use. As it stands, it's actually one of the must-have techniques for a foot and ankle surgeon. So it's a very commonly performed procedure in a foot and ankle elective list. So what are the indications? These, as I told you, have expanded in the last 2 to 3 decades. Let's start with impingement. You're all aware that ankles can become painful because of either anterior impingement or posterior impingement. It can become painful because of soft tissue impingement or bony impingement. And these are excellent indications for performing ankle arthroscopy. I would say it's one of the very common indications, anterolateral impingement and anteromedial impingement for anterior ankle arthroscopy. And many of the arthritic ankles will have anterior osteophytes over the distal end of tibia and on the talus, which are called kissing lesions. And taking these out is one of the most satisfying arthroscopic procedures. Septic joint, as with knee septic arthritis or septic arthritis anywhere, arthroscopic washout is the preferred way of washing out septic ankles. Osteochondral lesions. In my practice, I would say this is one of the very common indications, and almost always it's talar osteochondral lesions. It could be anteromedial and anterolateral. As it stands, the gold standard for talar osteochondral lesions is arthroscopic microfracture. So it's a very common and a very good indication. Ankle instability. This is interesting. In the past, when MRI was not being used that commonly in ankle pathologies, it was mandatory that we perform ankle scope when dealing with ankle instability, because close to 50% of these patients will have some intra-articular pathology, most commonly osteochondral lesions, but it could be impingements or loose bodies within the body, within the ankle joint. Now, more and more of these are having MRI scans. So we do know before starting the procedure what's going on within the ankle joint. Having said that, I routinely scope the ankles before doing a lateral ligament repair. And what's sort of increasing in incidence is arthroscopic lateral ligament repair. So this is a technique which I think will gain more popularity over the years, and may become the norm down the line. Loose bodies, as you all know, it's again a very satisfying procedure, doing a scope and taking a cartilaginous or a osteocartilaginous loose body out. Fracture reductions, I got to admit, I don't use it for this particular indication. But when you're doing a pilon fracture or talus fractures or medial malleolar fractures, you can scope the ankle and then see how good the reduction is. Some surgeons do it, but I don't use it for this indication. Next one is syndesmotic injury. This is again something which has gained prominence over the last a decade or so. As it stands, arthroscopic examination of the syndesmosis is considered the gold standard to diagnose syndesmotic instability. When you have doubt, when the X-ray is not clear, you have done MRI scan, it shows some ligament, syndesmotic ligamentous damage, you want to confirm that there is indeed instability, then the gold standard is arthroscopic examination of the syndesmosis. So that's something to keep in mind. And again, arthritis. In this, you could use ankle arthroscopy to fish out loose bodies, to remove osteophytes, and most importantly, to perform arthroscopic ankle fusion. It's a fantastic procedure, great results, and particularly if the deformity is not too big, it can be done very well with very satisfying results. I would say there's just one absolute contraindication for ankle arthroscopy, which is local soft tissue infection. If there is a soft tissue infection near the ankle joint, you would want to avoid scoping the ankle for the fear of introducing infection. Okay. A relative contraindication, you could say, is contracture, severe contracture of the joint, where you can't get into the joint. That could be considered a relative contraindication. Coming to the next subheading. So this is where it gets interesting. So what sort of equipment, what sort of technique we use to perform ankle scopes? Let's start with the arthroscope. There are two potential options here. One is a 2.7 millimeter scope and the other is a 4 millimeter scope. Each has its own advantages and disadvantages. In my practice, I use a 2.7 millimeter scope. The reason is, see, ankle is not as big a joint as the knee. So the space available for you is actually much more limited than the knee joint. By using a 2.7 millimeter scope, you can minimize iatrogenic cartilaginous damage. It's one of the complications of ankle arthroscopy, and this is higher if you use a 4 millimeter scope as compared to a 2.7 millimeter scope. On the other hand, the advantage of 4 millimeter scope is it gives you a wider view and probably a bigger and a better picture. But as I told you, I use a 2.7 millimeter scope. There are many foot and ankle surgeons who still use 4 millimeter scope. Thigh tourniquet. This is again not an absolute requirement. Most foot and ankle surgeons would perform ankle arthroscopy using a tourniquet. Okay, and I am one of them as well. I routinely use a thigh tourniquet, but you could do it without using a thigh tourniquet. In that case, so the next, as you see in the next line, you could use a pump instead of a gravity saline flow. I use a gravity saline flow because hemostasis is not an issue when you're using thigh tourniquet. But if you decide not to use a thigh tourniquet, you could actually send the saline into the ankle joint under some pressure, which will help with hemostasis. That's the advantage of pump, but the disadvantage is if the fluid is going into the ankle joint under pressure, it's going to extravasate into the soft tissues. So swelling and potentially compartment syndrome can happen if you're not very careful with pumps. So I don't use a pump. I just fill the saline using gravity. Most of my patients have general anesthesia when they have ankle arthroscopy, but it can be done under regional anesthesia as well. Right. So this is how most commonly patients are positioned, but it varies from country to country, and even within the UK, there are many different ways of positioning a patient. The black support you see on the thigh is called a thigh gutter. So the position of the thigh when I do it is not as vertical as it is here. It's more oblique, and you got to make sure that you're padded the thigh gutter well. Otherwise, it can easily cause pressure sores. It can impinge on nerves and cause undesirable side effects. But this helps with counter traction, and this also gives support to the thigh when you're performing ankle scope. Right. So there are two photographs here. One to your right is only of historical significance. So one to your right is the invasive ankle distraction. One to the left is the non-invasive or a soft tissue ankle distraction. Now, to my knowledge, it's the invasive ankle distraction is obsolete. I would strongly recommend that you don't use an invasive ankle distraction as it's not needed. Non-invasive ankle distraction gives sufficient distraction. Should you use distraction? That's the second question. Is distraction always needed? Probably the answer is no. Those who know Van Dyke is a very well-known, foot and ankle surgeon, and his own method of ankle arthroscopy, and he does not use ankle distraction. And there are, many surgeons who have been trained in that school who continue not to use ankle distraction. The disadvantage of not using distraction is getting into the ankle joint. If you want to examine the syndesmosis, if you want to examine the tibio-talar articular surfaces and the posterior aspect of the ankle, it can become difficult even with a 2.7 millimeter scope without distraction. So I would say distraction helps and certainly increases the joint space, which is what evidence supports as well. But you please note that it is not mandatory that distraction needs to be used. Okay. If you do use a distraction, focus on the photograph on the left-hand side, you will see a strap, ankle distraction strap around the patient's foot. It has got a stirrup which goes around the heel and a stirrup which goes on the bridge of the foot on the dorsum, and that's connected to a fixed device, which is, you clamp it to your operating table. The whole thing is sterile. You can sterilize it and apply distraction as needed. Okay. Right. So this is interesting. So to perform ankle arthroscopy safely, it is mandatory that we know the structures which go around the anterior aspect of the ankle. So we got to have sufficient knowledge of the tendons which cross the ankle joint, the nerves and the vessels, so that we stay out of harm's way and don't damage them, which can easily be damaged during this procedure. That way, it is actually much more riskier than performing a knee scope. In this diagram, you will see you see on the medial side, you're seeing two big tendons. Those are the two most important. One is tibialis anterior, and the second one is extensor digitorum longus. Okay, the first portal you make is called the anteromedial portal, and this is just medial to the tibialis anterior tendon. You got to be mindful that the great saphenous vein and the saphenous nerves are not far from this. When you palpate the tibialis anterior tendon, move the ankle dorsally and plantarwards, and when you move it dorsally, you will see a soft spot just medial to the tibialis anterior tendon, and that's where your anteromedial portal is located. You mark that with a marker pen before ankle distraction is applied, okay? And then move laterally. Laterally, you focus on the extensor digitorum longus tendon, and the second most common portal which is used, I would be wrong in saying second most common portal. The second portal which is always used is the anterolateral portal. The landmark is it's lateral to the peroneus tertius tendon. Okay, if peroneus tertius tendon is the lateralmost part of the extensor digitorum longus, in this diagram you see that it's going and attaching to the fifth metatarsal. That's not always present. If it's not present, then you take the lateralmost tendon of the extensor digitorum longus as your landmark, and it's located laterally in line with the ankle joint. Before you make this portal, it is mandatory that you mark out the superficial peroneal nerve. Okay, we all know that superficial peroneal nerve, it's variable in its course. So the easiest way to mark this is to plantar flex and invert the ankle, and you hold on to the fourth toe and bend it down. Okay, that makes the lateral division of the superficial peroneal nerve prominent. Okay, you could try it on your ankles. Actually, it's very easy to do, and you almost always see it. Sometimes you don't see it. If you don't, then this is where you put your line, in line with the fourth metatarsal in front of the ankle joint. If you can palpate it, just mark the superficial peroneal nerve, and your portal must be medial to this division, away from it, okay, so that you don't injure it. So those are your landmarks, and you marked your two anterior portals now. Okay, I'll just go to this portal section again. We know where the anteromedial portal is. It is medial to the tibialis anterior tendon in the soft spot okay, between the tibialis anterior tendon and the great saphenous vein. We know where the anterolateral portal is. It's in line with the ankle joint, just lateral to the peroneus tertiary tendon, avoiding the superficial peroneal nerve. And the final portal, which is occasionally used, not always used, but is helpful, particularly if you want to fish out your loose bodies from the posterior gutter. And it can act as a portal for outlet of your saline, is the posterolateral portal. This is located just lateral to the Achilles tendon, in line with the tip of the lateral malleolus. Draw a line along the tip of the lateral malleolus and just lateral to the uh, Achilles tendon. You make a mark and put a needle through this. Uh, One structure which can get injured in this is sural nerve. So, I'll be talking about that in tips and tricks, how to avoid injuring these nerves when you make portals. Right. This is one of the most important slides. So you've got your patient on table. He's anesthetized. You've put the thigh gutter and the distraction is on. You've made your portals, and the first thing you do after making the portals is take a 20 mils syringe, fill that with saline, go through the anteromedial portal into the ankle joint. The ankle joint, you never go 90 degrees. You always go at an angle, okay, inclined towards the foot. You enter the ankle joint and inject 10 mils of saline into the ankle joint. Once you have injected 10 mils of saline, leave the needle in, take the syringe out. You must see backflow of saline coming out through the needle. If you see this, that confirms that you are in the ankle joint. Once you've confirmed that you're in the ankle joint, insert the remaining 10 mils of saline. So 20 mils of saline in the ankle joint. The purpose of doing this is to avoid iatrogenic articular cartilage damage when you put your trocar in, okay? So next, you take the 2.7 millimeter trocar and cannula, make a cut on the mark that you made, and you use a technique called nick and spread. You make superficial cut in the skin, use a mosquito or an artery clip, and just go through the subcutaneous plane, open up your artery, go further in, open up your artery, and go through the capsule, and you should be in the ankle joint. This way, you can avoid damage to subcutaneous structures. Could be nerves, could be vessels, or tendons. Once you've made this, insert your 2.7 millimeter trocar and cannula. Take the inside bit out and insert the 2.7 millimeter scope. When you enter the ankle joint from the anteromedial portal, you will be seeing the ankle joint. It's very important to keep this in mind. You're going to see the ankle joint as if you're seeing an X-ray from the medial lateral side. Okay, from the anteromedial portal, you don't get an AP view of the ankle joint. You get a medial lateral view of the ankle joint. Okay, so you're seeing from the medial and you're looking at the lateral structures. So you will see most of the ankle joint. And one of the most popular ways of doing a thorough arthroscopy examination was first described by Ferkel. He's an American orthopedic surgeon, and he described what's called as a 21-point examination. I'll come to that slide and I'll show you what are the 21 points he's talking about. But your aim is to do a thorough examination of the medial gutter, deltoid, lateral ligaments, the anterior gutter, and the articular surfaces of talus and tibia. Not to forget the syndesmosis, which can be very thoroughly examined using an anterior ankle scope. Next is doing the anterolateral portal. every single time you do an anterior ankle arthroscopy, you must do the anterolateral portal. Okay, so as you do in knee, you put a needle through the predetermined anterolateral portal. You can see it from your arthroscope, and then use the nick and spread method. Put an artery clip and enter the ankle joint, and then you can put a probe or your shavers or your burrs through the anterolateral portal. Just one word of caution: every single time you do anterior ankle arthroscopy, please exchange portals. So if when you start off with anteromedial portal, you put your scope in. After satisfying yourself with the examination, change the portal. Put your scope through the anterolateral portal and your instruments from the anteromedial portal. This is because anterolateral portal is the one which gives you the anteroposterior view of the ankle joint. Okay, the anteromedial portal is going to give you medial lateral view, but this gives you an AP view. It will look as if you're seeing the ankle from front when you perform your arthroscopy using the anterolateral portal. And getting to the lateral gutter is a lot easier through the anterolateral portal than the anteromedial portal. And getting into the medial gutter is a lot easier from the anteromedial portal as compared to the anterolateral portal. So let's focus on the 21 points that Ferkel has described. Okay, apologies. This is a busy slide, but I'll just give you a couple of minutes to just probably a minute to go through this slide, uh, and then we can simplify it. It's have a look at it, and then we can simplify it. So Ferkel divides your anterior arthroscopy into three different parts: anterior, central, and posterior. So anterior part is about anterior third of the talus and anterior third of the ankle joint. Middle third is the central part, and posterior third is the posterior part. In the anterior third, you visualize the deltoid ligament, the medial gutter. So then you have the anterior third of talus. He divides that into three different parts: the medial, central, and lateral. And talofibular articulation, which is on the lateral side, lateral gutter, and the anterior gutter. Anterior gutter is the one which is anterior to the tibiotalar articulation. Okay. So very similarly, in the central third, you see that you visualize the medial aspect of the tibia and talus, central aspect of the tibia and talus, and lateral aspect of the tibia and talus. You're going to see capsular reflection of the FHL and syndesmotic ligaments in the central part. In the posterior part, very similarly, you'll see the gutters, the talus, and the talofibular articulation. All put together is your 21 points. When you start off, I think this is a very thorough and detailed way of examining ankle. So I would recommend that you start off like this, and when you gain experience, you can probably develop your own methods to make sure nothing is missed. So what are the tips when you perform arthroscopy? Like any orthopedic procedure, the more you do, the better you're going to get at it. This has become a common procedure in a foot and ankle surgeon's practice. So some of the tips which could help you are, so patient positioning. We saw that you place the patient supine, you use a thigh gutter. But one of the things we forget is our limbs. When you place a patient supine on a table, invariably the limb goes into external rotation. And this also happens when you put a patient in a thigh gutter for anterior ankle arthroscopy. If this happens, it actually is very awkward to do an anterior ankle arthroscopy, because the foot is going externally and you will have to turn out to, to make your portals and go into the ankle joint. So you can very easily prevent this by taking steps to prevent limb external rotation. You can use a big sandbag under the same hip as you would do when you do an ankle fracture fixation. That will turn the limb in and prevent this external rotation, and it can make your life a lot easier when you're doing a scope. Always pad your uh, thigh gutter or the thigh holder. I think in the photograph that was shown, there was a big foam between the thigh and the thigh gutter. That's very, very important. When you're performing arthroscopic fusion, uh, the patient will be in a distractor for easily over an hour, and could be hour and a half. If it's not properly padded, it can give rise to some very undesirable pressure effects, skin necrosis, nerve damage, and you don't want that to happen. So it's a must that the thigh holder is well padded. Superficial peroneal nerve is the most commonly injured nerve when anterior ankle arthroscopy is performed. So it's mandatory that you take steps to prevent damage to this nerve. Okay. What makes it difficult is the course of the nerve is very variable. As I told you in the previous slide as well, one of the easiest ways to mark this nerve is by plantar flexing and inverting the ankle, and at the same time press on the forefoot and plantar flex it. That makes the lateral branch of the superficial peroneal nerve prominent, and it is actually a thin cord-like structure which is palpable under the skin, and you can just mark it that way. Another tip I would say is don't double glove. If you own two gloves, it's difficult to appreciate this cord-like structure. So with a single glove, you can easily appreciate this cord-like structure under the skin, and mark it following that. Anteromedial portal marking is preferably done before the distractor is applied. This is because when you put the non-invasive distractor on the ankle, invariably the foot goes into plantar flexion because there is force pulling on the foot down. There is a force, a distracting force, which is pulling on the foot. So your foot invariably goes into plantar flexion. When the ankle is plantar flexed, tibialis anterior, you will see, moves medially. So if you try and make a portal after this has happened, you will be way medial to where you should be. And you will actually struggle to get into the ankle joint. So, mark this portal before you distract. And when the distractor is on, you should manually try and dorsiflex the ankle joint. That will take the tibialis anterior away from where you're trying to make the portal, and then that should, following that, you should easily enter the ankle joint. I talked about nick and spread technique. It's very, very important to stick to that technique to avoid damage to nerves, vessels, and tendons around the ankle joint. Always exchange portals. The number of times I have discovered something new when I've exchanged portals is just staggering. So every single time you do arthroscopy, exchange your scope from the anteromedial portal to the anterolateral portal. Okay, and as I told you before, your anterolateral portal is the one which gives the AP view of the ankle. Anteromedial portal gives the mediolateral view. So just I would like you to focus on this photograph. So A is the anterior gutter when the distractor is taken off. B is the anterior gutter when the distraction is on. So The star in the photograph is the neurovascular structure, and O is the capsule of the ankle joint. In B, you see that the capsule is really tight and the neurovascular structures are very close to the capsule. That's what happens when you distract the ankle joint. And you know the anterior gutter, which is in front of the tibiotalar articular surface. This is where many a time your loose bodies are there. This is where your soft tissue impingement procedures are done. Uh, this anterior gutter is important when you're taking the osteophytes out from the distal tibia. You can do all these. Actually, you must do all this by taking the distraction off, because when you take the distractor off, the capsule is relaxed, your neurovascular structures are well away from the capsule. That will reduce the risk of damaging the neurovascular structures. And it's a lot easier to maneuver the scope within the anterior gutter when the distraction is taken off. So you see that, actually there is more to ankle arthroscopy than what meets the eye. So you do apply a distractor, but you take it off when you do the anterior gutter examination. So you can perform your intra-articular examination, the tibiotalar examination first, and at the end, take the distractor off and perform whatever needs to be done in the anterior gutter. Okay, it works every time, and one of the important messages of my talk today, really. So we are nearing the end now. So this is one of my last slides. Complications. It's a very safe procedure, to be honest. But like everything else in orthopedics, we do see complications following ankle arthroscopy. Reported complication rate in literature is 2 to 5%. Most common are neurological. Most common nerve injured is the superficial peroneal nerve. And knowing the anatomy, knowing where the structures are, and diligently marking them out before starting the procedure can all minimize this undesirable and it's a totally unnecessary complication. Infection very rarely happens. It's less than 1 in 100 chance of infection, but it can happen after any procedure. Tendon injury. So extensor digitorum longus is one of the most commonly injured tendons. This most commonly happens when you're dealing with your anterior gutter and don't take the distractor off. So your capsule is very tight. You're very easy to damage the capsule. And once the capsule is damaged, you will see your tendons and neurovascular structures, they can easily be damaged as well. If your operation time exceeds 45 minutes to an hour, patients can get tunica pain. So that is something to keep in mind. But this usually resolves. So it usually is not very debilitating. Stiffness of the ankle very rarely happens. Swelling almost always happens, but resolves on its own. And complex regional pain syndrome, again, incidence is less than 1 in 500, but it can happen. It's totally out of anybody's hands, but it can happen. Right. So for more information, please read A Man's Surgery of Foot and Ankle. It has a big section on arthroscopy. And I would also recommend that you read Epstein et al.'s paper in Foot and Ankle Clinics. And thank you very much for patiently listening. Thank you.
Thank you, Kowshik, for a very comprehensive lecture. Fantastic. You have gone in step by step, looking at how to do a very good ankle arthroscopy. Just a few questions. See, Kowshik, you mentioned that one of the first portals that you always use is the anteromedial portal, isn't it? And that is going to be your viewing portal at that moment.
Absolutely.
My question is, if you put the camera in, and can we see from, I mean, you're looking from the outside, on the lateral side, you can see the lateral side, right, using the light from the inside of the ankle. And can that help you in identifying the nerve or any critical structures?
So yeah, okay. What you're asking is to make the anterolateral portal use this light
Yes,
to avoid damaging the nerve.
exactly.
Yeah, certainly. I mean, nerve probably not, but tendon certainly you can easily identify using this light. That's a very good technique, I would say. I don't routinely do it that way, but it certainly can be done to avoid damage to the tendon. Yes.
Thank you for that. The other question is, you mentioned about the distractions. I mean, the distractors that you use during your scopes, and you have a specialized distractor that comes in, right? So
Yes.
can we do see what happens is ankle arthroscopy is not, I mean, a lot of people do knee arthroscopy, but ankle arthroscopy is
Yes.
not very popular. Of course, it's catching up. So
Yes.
can we use a like a calcaneal pin and get the
Yeah.
ankle distracted?
Yeah. So that is definitely an option, and it comes under the group of invasive ankle distractors. In the past, that was the norm, say about over 2 decades ago. But if a center doesn't have a non-invasive ankle distractor, that is the next best thing to do. Put a calcaneal pin and distract it. You will be able to distract the ankle. Okay.
And
Uh,
from your point, you need to be careful only when you're doing the anterior most part, right? When you put in the distractor and you're
yes.
playing around the anterior part of the ankle, then you need to be careful.
Yes, anterior gutter. That is when you take this distract. You don't need distraction when you perform anterior gutter arthroscopy. It's best done without a distraction.
Thank you for that. The other question is a thigh holder. I mean, you have, I mean, in centers where you do the regular scopes, you may even have a specially designed thigh holder for arthroscopy ankle. But for a normal place where you don't have an exclusive ankle arthroscopy thigh holder, can we use the usual, for example, we keep the opposite leg in a hyperflexed abducted position when we do a femoral nail, isn't it? So
Yes.
can we use that kind of a holder for the same ankle arthroscopy?
Yeah, definitely. When some of the hospitals I've worked in didn't have a thigh holder. So what we used to use is the 90-degree screen holder that the anesthetists use. There is a 90-degree padded
Okay,
thing on which you put our drapes to
okay,
exclude the patient from the operating site.
got
You
it.
can put that and use that as your counter traction device. So yeah, that can be done. That can be done. But tie holder gives you, it's probably a safer way of doing it, and you can pad all the pressure points much better when you use a tie holder. But other counter traction devices can be used. There is no hard and fast rule.
And the other thing is, you mentioned about tourniquet pain, right? So that's
Mhm.
in general with, I mean, any lower limb procedures, you're going to have the same kind of tourniquet. Do you think there's an exaggerated risk when doing ankle arthroscopy? There's a high incidence of tourniquet pain or something? No, right?
Uh, so, I mean, I've been a consultant for over 4 years. In the last 4 years, I mean, touch wood, none of my patients have complained of tourniquet pain. I'm yet to come across a patient who has complained of tourniquet pain following ankle arthroscopy. So it is a small risk, very small risk, and you're probably right that talking too much about it will be exaggerating it.
It's
So
it's the standard risk with any, I mean, lower limb procedure. It's the same risk, isn't it? Or do we have an
it
exaggerated?
is the same risk or probably even less of a risk because it doesn't take long to do ankle arthroscopy. Most of the time, 45 minutes to 60 minutes, you can do most of the procedures, except your arthroscopic ankle fusion, which needs a little bit longer.
Okay, Kowshik, thank you for that. Kowshik, we have a lot of, I mean, we have a spectrum of listeners on our channel. We have residents, we have fellows, we have young consultants, we have senior consultants and professors as well. So someone who's a young, for example, a young consultant who wants to start off with ankle arthroscopy, what do you think would be a good case to begin with?
Good question. Very good question. I would say soft tissue impingement. anterolateral ankle impingement, which is most of the times due to synovium impinging between the articular surfaces of the ankle joint, is probably one of the easiest cases to do because there, while doing that case, the surgeon will do a diagnostic arthroscopy followed by removal of the impinging soft tissue in the anterior gutter. So I would say that would be one of the probably one of the best cases to start off with.
And what about loose body removal? Like
That
only
is another one. Yes, yes, yeah. I would add that to the list. Loose body removal is also a very good case to start off with, and very
because
satisfying as well.
yeah, because I have a concern with the soft tissue impingement because many of us wouldn't even diagnose the soft tissue impingement accurately.
Yeah, no, loose body removal is a very good case. Definitely, I would add to that list. Yes.
Okay. And do you have experience using? I mean, you mentioned about microfracture in the ankle. And
Yeah.
what about any chondral procedures like chondral site implantation or any of those procedures? What is your
No, I
experience?
have no experience with contrasite implantation. There were only a couple of centers in the UK who are doing it, Stanmore and Oswestry, and recently Oswestry have stopped doing it as well because I think it's to do with funding, it's to do with approval from the central organizations. It's a procedure which is not caught off and which has not become popular. So I have no experience.
And what about arthroscopy assisted ankle fusion?
Yeah, that's commonly done, and it's a fantastic procedure. Very good indication for arthroscopy of the ankle, and success rate is over 90% with arthroscopic ankle fusion. Yeah, one of the most common ways of fusing an ankle in the United Kingdom.
And Kowshik, before we conclude, we have had a lot of foot and ankle surgeons on our channel, and your lecture has been very, very good. Just a query about the syndesmosis. How exactly or accurately can you look at the syndesmosis? For example, if a patient has a syndesmotic injury alone, do you think an ankle arthroscopy, and you're not very certain whether syndesmosis is injured, whether to fix the syndesmosis, do you think an ankle arthroscopy assisted syndesmotic fixation would be good? Sometimes syndesmotic injuries are quite tricky, isn't it?
Again, very, very good question. Very, very good question. This is gaining in popularity. Arthroscopic assisted syndesmotic fixation is gaining in popularity because one of the major drawbacks of syndesmotic fixation is malreduction of the syndesmosis, particularly when not so experienced surgeons are fixing the syndesmosis. It's very easy to forget the fact that we need to get congruent reduction, and it's not easy to assess on X-rays whether the reduction is congruent or not. So studies have been done, and they say close to 50% of syndesmotic fixations are malreduced, and your arthroscopy can assist in reducing this error. Yeah,
So
and as I said in my talk, as it stands, arthroscopy is considered the gold standard to diagnose syndesmotic instability.
okay, thank you for that, Kowshik, because this is a really upcoming area because we've looked at some of the data. Like you said, there's a lot of mal reduction, and people have looked at various methods to look at intraoperative accuracy of the syndesmosis. And one of those is ankle arthroscopy, and then another one is an intraoperative CT.
Yes, absolutely. Intraoperative CT. We don't have that facility in our center, and I don't know any center in the UK which has that facility. But I think future plans in future, you will see centers using CT intraoperatively to assess syndesmotic reduction. That is definitely better than an invasive procedure like arthroscopy. But that's for the future. That's for the future.
Okay, Kowshik, I think that's all the questions we have. Thank you for this fantastic session. And also, we had really some excellent discussion points that we carried forward. It was lovely hosting you, and a lot of new a lot of new insight to this wonderful procedure. Thank you so
Thank you
much for
so much.
joining.
Thanks for hosting me. Really had a great time and appreciate it. Thank you so much.
Thank you very much, Kowshik.